Hello and welcome to Schein TV. I'm Peter Norton. Thanks for tuning in. In this episode, we'll be looking at what's new in the delivery of local anaesthesia for our patients. Specifically, we'll be taking a look at computer-controlled local anaesthetic delivery. We'll have a real, live patient in the chair, and you'll get to see me try it for the first time on a patient. To guide me through the procedure and to talk to us tonight about the topic, we're joined by Dr. Eugene Casagrande, who has lectured internationally on computer-controlled local anaesthetic delivery. Gene, welcome to Sydney. Thanks for being with us at Schein TV.
Peter, thank you for inviting me. It's a great pleasure for me to be here to share with my Australian colleagues the experience and expertise that I have about computer-controlled local anaesthetic delivery. So it's a great pleasure to be here with you.
It's great to have you. Our event this evening is scheduled to run for approximately 1 hour. We'd like for this discussion to be as interactive as possible, so we'd encourage you to send us your questions throughout the event. In order to do that, please take out your smartphone right now, open the browser on your smartphone and go to the website shown on your screen. It's schein.tv. Once you've done that, click connect and you're good to go. You can ask as many questions as you'd like and we'll get to as many questions as time allows. By joining us here this evening, you're eligible to claim 1 hour of scientific CPD. At the end of the event, you can register to receive your CPD certificate by clicking the button below the video. So before we begin, let me tell you a bit about our guest. Dr. Eugene Casagrande has practiced cosmetic and restorative dentistry for over 30 years in Los Angeles. He is past president of the California State Board of Dentistry and the Los Angeles Dental Society, and he's a fellow of the American and International Colleges of Dentists. Dr. Casagrande was a member of the faculty of the University of Southern California School of Dentistry. He was also the executive director of the Los Angeles Oral Health Foundation and the program director of the Los Angeles Pediatric Oral Health Access Program. As a Director of International and Professional Relations for Milestone Scientific for over 17 years, he's published multiple articles and has lectured around the world on computer-controlled local anaesthesia. Gene, why don't you start by helping us to define our terms? What exactly is computer-controlled local anaesthetic delivery?
Well, basically, Peter, it's an instrument that produces a flow of anesthetic that is precise, consistent, and that it's below the patient's pain threshold. So it's going to allow us to do not only the injections we've been doing for the last 165 years with this technology called a dental syringe, but it's going to allow us to do injections that are newer injections. They're going to be very beneficial for our patients, more comfortable for our patients, and less stressful for us as dentists.
So in the context of like the historical context of local anaesthesia, where does computer-controlled delivery sit?
Okay, just a little bit about the history of local anesthesia. Most of the developments in the field of local anesthesia have been in the development of the drugs. So way back in the early years, we used to use cocaine for mandibular blocks. Then came Novocaine, then came the lidocaine, which is pretty much the gold standard in many parts of the world. And then came the different drugs like bupivacaine, articaine, all the other drugs. So most of the developments in the field of local anesthesia have been in the field of the development of the drug until 1997, when Milestone Scientific brought to the dental profession something called the wand. It was the first computer-controlled delivery system. And since then, it's been on the market and been used throughout the world. Now, after the initial generation, there was another generation. It was called the Wand Plus. And that's still being used by many dental offices all over the world and also in Australia. The instrument that we're going to talk about today is the third generation of the wand. It's called the Wand STA. And STA stands for single tooth anesthesia, although it does every injection, like I say, that can be done with a syringe.
So I think a lot of dentists will ask, I can already get my patients numb with a conventional syringe. Why essentially would we bother with the time, the training, the expense, at least initially, of a computerized system?
The bottom line, like I said, is going to give us the ability to make injections much more comfortable for our patients and less stressful for us, as you're going to see with the newer injections we're going to talk about this evening.
So my understanding is the computerized anaesthesia can deliver the whole range of anaesthetic techniques we can already do.
Yes.
What are the unique techniques that are specific to computerized systems?
Well, because we can control the flow of anesthetic and because we can produce a flow of anesthetic below the patient's pain threshold, we can do some interesting injections that we're going to discuss. For example, we can do an injection that just numbs a single tooth without collateral numbness to the patient's lip and face. I'm going to show you that. In fact, I think that's one of the injections you're going to do this evening. And then we can also do injections in the palate that numb multiple teeth and all the related tissue without numbing the patient's lip and face. So it has many benefits to our patients and to our practice as far as efficiency, as far as being able to assess the smile line if we're doing cosmetic dentistry. We'll go into a lot of that. But basically, we're not using a 160-year-old technology on the one part of the dental procedure that our patients are more concerned about. Okay, this is the one thing that they hate to see. What we're going to show you is an alternative to the dental syringe that not only does all the injections that are done with a syringe, that you can use all the anesthetics that you want to use with the syringe, but more comfortably and less stressfully.
If you've just joined us and want to send through a question, take out your smartphone, open the browser on your smartphone and go to schein.tv, then click connect and you can send your questions through your phone. So what would you like to start by showing us, Jake?
Well, I think what we could do is start to show you the instrument and how it works and some of the features that it has. Now, of course, when you have a new innovative technology, a revolutionary actually technology in the field of dentistry, there's a lot of people that want to copy it. So there's products from around the world that are available. I don't know if they're available in Australia. They're available in some parts of the world. They're computer-controlled delivery systems, but they don't have anything like the benefits and the features that are in this particular instrument. So you can go online and see, other computer-controlled delivery systems. Some of them look like a missile. Some of them are very bulky. If I came at a patient with one of these instruments, they'd probably freak out. So, this instrument, as we're going to see, is very useful, has many benefits, like I say, that some of the other instruments don't have. As you can see, this instrument is very simple. I can show you that there's a power cord in the back, and there's a foot pedal that screws into the front. And then there's a switch in the back that turns the instrument on. And it takes about 5-6 seconds to boot up because there's a motherboard in there. That's the computer part of the instrument. So wait 5 or 6 seconds. Now you can see some lights that come on. Basically, these lights tell us some of the features that this instrument has. For example, this is aspiration. It can be turned on or off, and we'll leave it on all the time, and I'll tell you why, even though we're going to be using it on injections that we don't have to worry about aspirating into a blood vessel. But when we want to pull the instrument or the needle out of a tissue, we'll go into aspiration, and then we won't get any anesthetic in the patient's mouth. We'll show you that. As you can see, there's a volume control here, so we can make the sound very loud, or we can make it very soft, depending on the office. You can see that this lights denotes that the mode goes to STA, and we'll show you what that means. That's, as you're going to see, the flow rate of 1 drop every 2 seconds. We call it the control flow rate.
And STA stands for single tooth anesthesia.
Yes.
But it's not just for single tooth.
Not for just that. The flow rate we're going to show you is used in the palate for those 2 injections I'm going to show you, the AMSA and the PASA, and for also the intraligamentary injection that I'm going to show you. So it's useful for those injections. Then I'm going to show you that there's another mode called the normal mode, and that is going to give us 2 flow rates, which I'll show you. Okay? So we'll keep it on the STA for now. Now, we use something called a wand handpiece. Okay? It comes in a sterile package. It's used 1 per patient. It's disposable. And it comes in 3 different size needles. The needle that I'm going to show you and you're going to use today on the 2 injections you're going to give is a 30 gauge half-inch needle, okay? But it also comes in a 30 gauge 1-inch needle that is usually the one you're using now, the blue cap needle that you use for an infiltration. And then it also comes in a 27 gauge 1.25 inch needle that can be used for the mandibular block. So again, we can use these needles for all the injections that we're doing now with the dental syringe. So we break open the wand handpiece package, and we can see that there are 3 parts to this wand handpiece. The first part is a cartridge holder. And as you can see, there's a spike that's going to penetrate through the membrane on the cartridge, okay? And then it's attached to a microtubing, so the patient could be here, and the instrument can be behind the patient or anywhere else. Also comes with a little trolley so you can move it, close to the patient. So what we do is take your cartridge and pierce through the membrane. Okay. Now, we have what we call a little part for the cap, so that it can be on either side of the instrument. There's one on either side. Now, in Australia, you're special people.
We have the carpal difference.
Yes, you use 2.2 cartridges. Okay, so we have a special adapter that we use for the dentists in Canada, Australia, England, that use a 2.2 cartridge. So we'll put this into the adapter, lock it. Then you can see there's wings here that will fit on the top of the instrument. And we put it on the top of the instrument, and then we turn it 1/4 turn to the left. Now you can hear it's actually purging the air out of this handpiece. And it's loaded now with the anesthetic and ready to go. So if I was going to demonstrate these flow rates, they're initiated with the foot pedal. And if I depress the foot pedal down at the STA rate, we're going to produce what I said is the 1 drop every 2 seconds. So I'm going to hold the foot pedal down, and you're going to hear beep, beep, and then the voice will say cruise. When the voice says cruise, I'll take my foot off the foot pedal, and it's going to be on cruise control, just like your car. Okay? So let's do that. So I'm going to depress the foot pedal down.
Cruise.
She said cruise. I take my foot off the foot pedal, and it's going to stay at this flow rate throughout the whole injection until I tell it to stop.
And how would you tell it to stop?
Okay, we will hit the foot pedal. If the aspiration is on, it'll go into aspiration. So to stop it, I will hit the foot pedal and release, and it'll go into aspiration. And if I'm in a blood vessel, I'll see blood in this area. And in fact, it's a true aspiration. You know, a syringe can actually aspirate blood outside the vessel. So let's say you're doing a block and you've nicked the blood vessel and there's some bleeding outside the vessel. So you use an aspirating syringe, it'll give you a false positive. Our studies show that this needle actually has to be in a blood vessel in order for it to aspirate blood.
Do we yet know how that's possible, or is it just how it is at the moment?
Excuse me?
Do we yet know? I mean, it sounds as though the physics of puncturing or nicking a blood vessel would be the same regardless of a...
Surely, but in fact, our studies show that you actually have to be in the blood vessel. You have to have the pressure of that blood vessel in order for it to aspirate properly. And it's a short aspiration. The original wand, some years ago, took actually 13 seconds to aspirate. So now this is a quick 4-second aspiration.
Beautiful.
But it's a true aspiration because you're holding the needle in place and you're initiating the aspiration with your foot. So the needle could be held very steady.
Yes,
Okay.
as opposed to a conventional syringe
Yes.
where there could be
Yes.
some movement.
Yes, exactly. Now, if we're going to do an injection like I suggested with when we need an extra amount of flow rate, then we can go to what's called the normal flow mode. And in that flow mode, we have 2 flow rates, okay? So let's say, for example, I'm going to do an inferior alveolar nerve block, a mandibular block, with a longer needle, of course. Basically, I would start the flow rate, or start the injection with the control flow rate. So I would go into cruise control, take my foot off, I'm on cruise control. And when I reach the injection site, if I needed to, I could aspirate. I aspirate just by hitting the foot pedal. It's a quick aspiration. If it was a negative aspiration, then I could go to a faster flow rate. In other words, when I'm in tissue that's expandable, then I can go to the rapid flow.
So
and the rapid
initially-
flow is when I just depress the foot pedal all the way down, and then we would get a rapid flow, and the patient wouldn't feel this either. You just heard gong. That just told me 1/4 of the cartridge was finished.
Oh, good.
So it'll tell you, and you'll hear gong gong just a second, that the half of the cartridge is finished. Okay? So basically, we can use those two flow rates to do every injection we can do with a syringe. Okay?
Perfect.
And we're not dependent on the manual pressure of a syringe. Now, some people say, well, wait a minute, it takes a little bit longer to give the injection with this. Not really. Okay, at that fast flow rate, it would take about 50 seconds to dispense a full cartridge. And that's the amount of flow, the time that we're supposed to be taking to give, a proper injection. We're all taught to take about a minute per cartridge. And so this lets you use the proper amount of time to give an injection. But a minute's not too much time to give a proper injection.
Excellent. So what's the first technique you'd like to show us that's unique to a computerized system, or this particular computerized system?
Okay, what we can do with this system, another core technology that I should mention is the ability to control the needle. Okay, you saw that we use a wand handpiece. It's a lot less threatening than the syringe, and we hold it like a pen. So I'll give it to you and let you hold it. You can see you hold it like a pen, and it's lightweight, it's ergonomically designed. You have excellent control of the needle. It gives you great tactile sense. So you basically feel everything as you're going through tissue. When you hit the bone, you'll feel that because of the tactile sense you have with this. Very lightweight and easy to control.
There's also the capacity to rotate, isn't there?
Yes. So the first injection we maybe should talk about is an inferior alveolar injection, mandibular block injection. Okay, with the syringe, and maybe you could put up the needle deflection. That's good. So with the syringe, when we give a syringe injection, it's a linear injection, it's a straight injection. And because we're using monobevel needles, the needle can deflect one way or the other depending on the orientation of the bevel. So we can't really do anything to change the orientation of the bevel with the syringe injection. But with the wand injection, using a longer needle, of course, what I can do is rotate the needle as I'm going through the tissue to the injection site to make the needle go straight. And that's important because we're closer to the injection site. Okay, and because we're closer to the injection site, we will have fewer missed blocks, and we'll have really short onset of anesthesia in the 2 to 4 minute range. You don't have to wait 5, 10, 15 minutes for the mandibular block to take effect. And also, we have 2 studies on children, recent studies that show that there's less pain perception, at least on children. Can't say that about adults yet, but at least in children, less pain perception. So that's why even those dentists that want to use this just for infiltrations and blocks, they can use this birotational insertion technique very well. Okay?
Nice.
So basically all the injection sites are the same. The amount of anesthetic that you're going to use is basically the same. You use the same volume. So it really shouldn't take you any longer to give an injection with the wand than it is with a traditional syringe if we're doing it properly. Okay. The next injection that we should talk about are a couple of interesting injections in the palate. Okay, because of this technology, that control flow rate, and the ability to control the needle, we can do injections in the palate that really don't give collateral numbness to the patient. Okay, but they anesthetize multiple teeth. They were discovered because of this technology. So the first one that we should talk about is an injection called the AMSA. The AMSA stands for anterior middle superior alveolar nerve block. Okay, so it's an injection that gives us that scope of anesthesia. But if we think about a palatal injection, Peter, I mean, we've all given palatal injections.
Nobody likes them.
They're the most difficult to give, and of course for our patients, they're the most difficult to receive. So basically, we have developed some techniques that make it very, very comfortable to give this palatal injection. This is the injection you're going to do. So pay attention. This is going to be great that you're going to do it for the first time. So basically, this injection has 3 parts. And in fact, all injections have 3 parts. There's the initial puncture of the tissue. Secondly, the second stage of an injection is the penetrating the needle through the tissue till we get to the injection site. In the case of a mandibular block, we have to go through a lot of tissue. In the case of this palatal injection, we're just going to go through the palatal tissue till we reach the bone, which is the injection site. And then thirdly, when we're at the injection site, we have to deliver the anesthetic. And that's how most people feel discomfort during an injection. It's when we deliver too much, too fast, in a confined area, the tissue can't take it. And so it distends and the patient feels pressure, they feel discomfort. But with this flow rate, as you're going to know, the delivery of the anesthetic is the easiest part. Well, let's take each stage. We know that topical anesthetic works well when it's in mucosal tissue, but when it's on palatal tissue, it really doesn't work so well.
Why doesn't it work so well?
Because the epithelium is so dense that it just doesn't penetrate down to do any good, I would think. At any rate, we have developed a pre-puncture technique that works quite well. And this involves finding the bevel of the needle, that flat spot, and putting it on the injection site, on the tissue at the injection site. Now, the injection site for this injection is an area between the middle of the palate and the free margin of the gingiva, and it bisects the premolars. So it's an area, it's not a particular point or a canal we're trying to enter.
So there's some leeway.
Yes, you could be anywhere in this general area and it's going to work. So the pre-puncture technique involves finding the bevel of the needle and laying it on the tissue very, very lightly. And then with a cotton tip applicator, we put pressure on the back end of the needle and on the tissue. And then we start our flow of anesthetic. So we hit the foot pedal and it goes beep, beep, cruise. We take our foot off the foot pedal and now we're on cruise control throughout the whole injection. Now, after about 10 seconds, we have what we can call surface anesthesia. It's really a combination of pressure anesthesia and forcing some of the anesthetic into the first couple layers of the epithelium and the palatal tissue. So after 10 seconds, I'll take this away, and then I'm just going to rotate the needle back and forth to just barely pierce the tissue. And then I pause. I don't go any deeper at this point. So before I start the second stage of the injection, what I want to do is cause some anesthetic to go into the tissue so that we'll cause what we can call an anesthetic pathway. So we'll pause for 5 or 6 seconds, let some anesthetic go. It's always going at that controlled flow rate. And during that pause, what I want to do is just rotate the needle so I'm going directly down into the tissue, to the bone at the shortest route. And I want the flow rate to go towards the premolars. Okay, so I don't want the flow rate to go towards the soft palate. Then after 5 or 6 seconds, I start to slowly penetrate the needle down through the tissue.
With a rotational motion?
Yeah, it just kind of makes the needle slide through the tissue quite easily until I reach the bone. Now, I'm in no hurry. It may take me 8, 10, 12 seconds to get to the bone. But basically, I'm moving this needle through pre-anesthetized tissue because I know exactly how much anesthetic is coming out of that needle. It's 1 drop every 2 seconds. So if I move the needle slowly through pre-anesthetized tissue, the patient doesn't feel the flow of the anesthetic. And so finally, I'll hit the bone. And when I hit the bone, I'll stop. I don't want to penetrate through the periosteum. I don't want to go any deeper. And I would just want to let the anesthetic flow at that flow rate. This instrument is doing all the work. We don't have to rely on our manual pressure of our thumb on a syringe. This is consistent, it's precise, it's always below the patient's pain threshold. So there's really nothing to do. Once we reach the bone, we just sit back and relax.
And how much of an Australian carpule would you deliver to that site?
Well, it actually depends on the drug that you're using, okay? In America, we use a lot of lidocaine, and that's the drug that I really recommend for this injection. So on a normal patient using lidocaine, we can deliver 3/4 to a full cartridge of anesthetic. okay? Now, if we're going to use articaine, which I know is very, very popular in Australia and in many parts of the world, then I would suggest using no more than half of a cartridge. So when we're using a 4% drug like articaine, we have to be concerned about the dosage, and we have to cut the dosage in half. So whereas I would use 1/4 of one full cartridge of lidocaine, usually 1 to 100, using articaine, I would use half of a cartridge. And better if we can use 1 to 200 epinephrine rather than 1 to 100.
So one of our questions we have from our online audience is, can we use the pre-puncture technique, essentially using a conventional syringe?
Yes, you can. It's just that it's so much more difficult to use. With a traditional syringe, with this injection, you're going to poke into the tissue, okay? But you can still do this injection with a syringe. Of course, if you're going to try and reproduce that flow rate that this instrument will produce, you know, after about 30 seconds, your thumb's going to want to fall off. Because remember, you have to increase the pressure on the thumb to overcome the resistance of that palatal tissue. And then when the pressure on your manual pressure on your syringe overcomes that resistance, the anesthetic floods out and the patient in a burst, and the patient jumps, they feel it. With this injection, it's a very, very comfortable injection.
Great.
It's due to the flow rate and the ability to control the needle. I mean, here we can use the finger rest. With a syringe, it's very difficult to use a finger rest. So I would say anything can be possible. And as a matter of fact, if you inject the same amount of anesthetic in the same place, you're going to get the same anesthetic effect. It's just that this instrument makes it much more comfortable for you and your patient, less stressful for you and your patient. So, the other injection I'd like to talk about in the palate is one we call the PASA. And this injection is going to numb all the anterior 6 teeth from canine to canine, okay? Now this injection is, you can see here on the screen, the scope of that injection. Okay, it injects all the palatal tissue and all the labial tissue.
But doesn't seem to numb the tissues of the face.
No, the lip and face is completely normal, as in the previous injections. And I should say about the previous injection, if we were numbing a whole quadrant, let's say for quadrant scalene and root planing, if we gave that AMSA injection that we talked about, and then gave a traditional infiltration behind the second molar, we've now, with 2 injections, numbed the whole quadrant. It would take the place of 6 injections, 4 infiltrations and 2 palatal injections. So that's the value of this technology, is the ability to use much less volume of anesthetic. Can you imagine how many cartridges you would use to do 4 infiltrations and 2 mandibular blocks? We did a study in the University of California in San Francisco on 20 patients, and all the healing was the same, the scope of anesthesia was the same, the duration of anesthesia was the same. So the advantage, of course, is the patient could leave without their lip and face completely numb.
We have a question about hard to reach areas, specifically relating to bending the wand needle, and whether a rotational approach is recommended there. What are your thoughts on that?
Well, it depends on the injection. I mentioned that we rotate the handpiece when we're doing the mandibular block. As you're going to see when we do the intraligamentary injection, we would bend the needle slightly towards the bevel so we can see where the bevel is. So in general, we don't need to bend the needle other than with the intraligamentary injection I'm going to show you.
But when the needle is bent,
Yes.
Presumably we wouldn't use the birotational?
No. When you're using the birotational insertion technique, or when we're doing these injections in the palate, we don't bend the needle. So let me show you this other injection in the palate called the PASA. Now this is an injection where we're going to enter the nasal palatine canal. And the injection site is just lateral to the papilla, the incisor papilla. You know, behind your 2 centrals, you have an incisor papilla. It's very, very dense tissue. So you don't want to inject into that papilla, but you want to start the injection just lateral to that papilla. So we do our pre-puncture technique. We lay the needle just lateral to the papilla. We come in with the cotton tip applicator and we put pressure on the back end of the needle. Then we start the flow. So we hit the foot pedal, it goes beep, beep, cruise. I take my foot off the foot pedal, now we're on cruise control. Once again, after about 10 seconds more or less, we have surface anesthesia. So I take the cotton pellet away, and I just barely rotate the needle to just barely puncture the tissue. The patient doesn't feel that. Now, I'm gonna let some anesthetic flow, all right, always at that controlled flow rate, until I see the papilla blanch. When I see that papilla turn white, that's an indication that I will rotate the needle vertically and then slowly go down into the incisive canal. Okay, now when do we stop? We stop when we arrive about halfway down through the length at the length of the needle, or if we hit the internal wall of the canal. Now, what's a little bit different about this injection is we need to aspirate because there's a blood supply in that canal. So we just hit the foot pedal and release it. It goes into aspiration. We have negative aspiration. We go back onto cruise control and we deliver enough anesthetic to numb the 6 anterior teeth and all the related tissue without numbing the patient's lip and face. Yes.
So presumably this would be ideal for aesthetic work.
Yes, when you're doing
you've got smile
composites,
line.
aesthetic dentistry. Yes.
And what would be the duration of anesthesia there?
It would be the same as for an infiltration. So you're getting an hour or an hour and a half worth of anesthesia. Yes, and the amount of anesthetic that we're going to deliver, again, depends on the drug that we're using. If we're going to use a 4% concentration of drug, I would not use any more than 1/2 of a cartridge on this injection. In other words, articaine, better 1 to 200. If you have to use 1 to 100, that's okay. The injection onset is very rapid. So you can take this out. And when I would say take this out, I would hit the foot pedal, go into aspiration. And in the middle of aspiration, after the 3rd beep of aspiration, I would take the needle out. Okay, we're going to do that. I'll walk you through your injection in the palate. I'll mention now, hit aspiration, beep, 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 out. And we won't get anything in the patient's mouth by doing it that way.
Sounds good.
Okay. Now, there's another injection I want to talk about. It's called the intraligamentary injection. Now, we've all had the experience of doing the PDL injection as a last resort injection. You know, when the first mandibular block injection doesn't work and the second one doesn't work and you've got a tooth that's, you know, acute pulpitis, let's say, a hot tooth, what do? We pull out a pressure instrument, either the syringe or the peripress or ligament jet. And what do? We put that needle into the sulcus, force it down to the PDL space, and force as much anesthetic as we possibly can. Okay, basically we're only injecting maybe 1/10 of a cartridge using that technique. It hurts the patient, as we know. The patient feels it, and postoperatively they'll even come back, even if you've taken out the nerve of the tooth. They'll come back because the tissue has been damaged, and there's bone resorption. So this injection, and maybe we're going to get 10-15 minutes worth of anesthesia. That's about it. So this injection we're going to describe right now is completely different in one major respect. That is that we're not going to use any pressure. As you're going to see, we're going to put this needle into the sulcus of the tooth. We're going to move the needle down until we reach resistance, like a perioprobe. And then we're going to just hold it there with no force or pressure on that needle. We're going to let the anesthetic flow into the bone around the tooth.
On cruise?
On cruise control, on the cruise control or the STA mode, the 1 drop every 2 seconds. Okay, so it's a wonderful injection that's going to give us 45 minutes or more worth of profound anesthesia just around that tooth. So in many cases, it eliminates the block. Okay, so when you start using this instrument, one of the major benefits is that we don't have to give a block in most cases. Now, I don't know about you, but to me, giving a mandibular block, my patients didn't like it, especially for the 2-3 hours that they had to have their lip and face and tongue numb. But also, for me, it was a little, how would you say, stressful?
Stressful, absolutely.
And I remember, because I haven't practiced dentistry for some years now, but I remember when I gave a mandibular block, I was holding my breath throughout the whole injection. Now, I don't know about you.
No, you are not alone in that.
Okay, and I challenge my colleagues here that the next time you give a mandibular block injection, if you're holding your breath through the injection, kind of waiting for the patient to feel something, to jump in some way, that's not good. That's stressful. Life is too stressful. Dentistry is stressful. We don't need to cause undue stress. So as you can see, this injection is very, very beneficial to our patients, but it's a lot less stressful to us.
So what's the technique?
Okay, let me show you. First of all, let's talk about the injection sites. Every tooth has 2 injection sites, except lower anteriors. They only have 1 injection site. But if we're going to do, let's say, any maxillary tooth, we're going to start on the distal buccal line angle, and then we're going to the mesial buccal line angle. Okay, we don't have to do anything on the palate or lingual tissue.
And how much of a carpula are you dispensing?
Well, again,
at those
it depends on the drug we're going to use. Okay, if we're going to use articaine, we're going to deliver no more than 1/4 of a cartridge per site. Okay, if we're going to use lidocaine, we're going to deliver half a cartridge on the distal, and then the rest on the mesial. Okay, now on lower teeth, on mandibular teeth, we go to the lingual. So we're going to use the distal lingual line angle and then the mesial lingual line angle. It's very important to always start on the distal and then go to the mesial. We learned that in a clinical study out of Boston University in America.
Do we know why, or that's just what works?
We know that the success rate is completely different. In fact, they had to start the whole study all over again because the success rate was so completely different. I would think that, especially with using lidocaine, you're injecting a half a cartridge on the distal. That's where the nerve comes from. So you want the bulk of the anesthetic to go on the distal. The rest on the mesial is not quite a half a cartridge because some is still left in the tubing and some is purged during the purge cycle. So if I was going to do an injection on a lower molar, for example, let's talk about that. I think you're going to do one on upper cuspid or canine. We'll talk about that too. But you know, this wand handpiece is so large that it really can't get into the patient's mouth to give us good access unless you're working on a lion or a tiger. So what we do is we break it down. And that's just simple. Basically, there's a little channel that this wand hand microtubing fits into. So we take it all the way down, and then there's a little notch at the bottom here that we're going to just snap off. On a child, I give this to the child and say, oh, this is the magic wand from Harry Potter. You know, use that, hold that. So now we have a short handle handpiece, okay, that can give us access anywhere in the mouth. The next thing I want to do is find the bevel of the needle and just barely bend it just slightly towards the bevel, okay? And what that does, it allows us to know where the bevel is. Now you can see it a little bit better. So I know when I'm in the mouth and I'm giving the second injection at the second site, maybe there's one drop of anesthetic at the end of the needle. Well, now I'll know where the bevel is because the bevel must be towards the tooth. So if I was going to give an injection on this lower molar, I would approach the tooth at 45-degree angle with the bevel towards the tooth. Okay? Now, the real trick here is to hold this lightly and hold it like this with two fingers, your thumb and forefinger. You can't get your whole hand in the mouth like this. So if you hold it very lightly with 2 fingers, we put the needle into the sulcus, and then I hit the foot pedal and start the flow and go on to cruise control. As I'm doing that, I move the needle down until I reach resistance, until I hit the bottom of the sulcus. At the bottom of the sulcus, basically I'm at the top of the PDL space. I don't go down any further to break any periodontal ligament tissues. I hold it there and let the anesthetic flow. Now the way that we don't get success on this injection is typically because we're putting too much pressure on that needle, which, you know, is what we're used to doing. So it's really the opposite of what we think we want to do, okay? So basically we hold this needle here. Now, one of the unique features of the wand handpiece, of the wand system, I should say, is that it has something called dynamic pressure sensing. And this is going to tell us when we've arrived at the proper spot to give this injection by lights and sounds. And basically, I can show you what it's going to look like and sound like on the instrument as we start the flow of the anesthetic.
Cruise.
I'm on cruise control. Now you're going to see the sound that it's making, and the lights are going to go from red to yellow
And this is sensing pressure.
Yes, it's sensing pressure to tell us that we've arrived at the proper spot to give the injection. Now, Peter, what it won't tell us is that we're using too much pressure on the needle. Okay? If that's the case, then this will just stop at a certain, like 350 pounds of pressure. Okay? It's like a fail-safe. Okay? When we get to the, I'm using this on just a type of it, but typically it'll go from red to yellow to green, and then it'll say PDL, PDL. That tells us that we're in the proper spot. Now, do we have to get those lights all the way to green in order to get anesthesia? No. If it gets up into the yellow range, we know we're in the right spot. As long as we hold that handpiece lightly and allow that anesthetic to flow into the bone, we're going to get anesthesia.
So we've had a question regarding STA. I found that I can't do single tooth anesthesia with my wand. This is a patient, a dentist who's using it on some patients. Essentially, it doesn't work in about 20%. Do you have tips for success? It sounds as though the answer would be less pressure.
Absolutely. If I could ask the doctor if he ever saw this instrument just stop and say, relocate, relocate, that's the fail-safe that they've used so much pressure on the needle that they've just blocked the flow. Everything is backing up into the microtubing, and you're not going to get good anesthesia. So the tips, there's two main tips. Mainly, the first tip is to hold this lightly, hold the handpiece lightly, so you'll feel the bottom of the sulcus. Because if you go down too deep, that won't give you good anesthesia, and the patient will feel it. When we do this injection correctly, I can truthfully say the patient should feel nothing during the injection or postoperatively, okay? That's pretty hard to say, but that's what happens, okay? Now, the other cause for lack of success is pressure or force on this needle that blocks the flow, okay? So what we have to do is when we reach the bottom of the sulcus is stop and just hold it in place and don't put pressure on the needle. And this is what happens. Some dentists are more concerned about getting the lights to green, so they'll start moving the needle around or putting pressure on the needle to get the lights to green. If you get it up into the yellow range, that's probably where it should be. And just hold the needle in place without force or pressure on the needle, and you'll get anesthesia.
That relates to another question about the risk of tissue damage to the PDL, I guess. What are your thoughts on that?
Okay, we've done clinical studies on that, many years ago on mini swine at New York University, where they sacrificed the animals and then did slides to show that there's no bone resorption and there's no tissue damage with this injection. Why? Because we're not using pressure. Basically, we're letting the anesthetic flow, and this instrument is doing all the work. Okay, so yes, there's no damage to the tissue. Now, can there be damage to the tissue with this instrument? Yes. And that's normally because the dentist has used too much, has overdosed the tissue. So when I said be careful when you're using articaine and don't give any more than 1/4 of a cartridge, some dentists just don't pay attention, they use too much, and then you run the risk of having some tissue adversity. Okay, so basically, if you stay within the guidelines that we recommend, it's a comfortable injection and you won't have any problems.
Well, I think it's time to work on our live patient.
That's good.
So
let's try it.
A question that came in earlier was about the risk of complications in things like...
I could show you that we just turn this to the right and then we take this off and then change the cartridge. Yes.
So getting back to the question, there was a question about does the wand help to reduce the risk of paresthesias in...
Sure, because if you're going to do the intraligamentary injection and not have to do a block, I mean, you're not having the risk of trismus, or paresthesia. So yes, it does, handle that problem.
But I suspect that the question was mainly related to an inferior alveolar nerve block.
Sure.
Does it have any bearing on the risk of?
No, basically, because all the landmarks are the same, you're basically putting the same amount of anesthetic in the same place, you get the same anesthetic effect.
Sure.
So if you're going to do a block using whatever drug, you're still running the risk of having the same tissue reactions you would have, with the regular syringe.
Understood.
So that's the value of this, is to be able to not do a mandibular block, and that's important.
Big help. Well, everyone, welcome Mark. Mark works with Henry Schein Hallis, so he's very much putting his money where his mouth is, or something in that regard. So Mark's very kindly volunteered to be our patient today. So which technique are we demonstrating first, Jean?
Well, why don't you do the AMSA injection? You've never done it on a patient. He's never had one before, as I understand. Is that correct?
That's correct.
Okay, so let's see how it goes. I'll walk you through it.
Beautiful.
Okay, it's not rocket science. This is a sterile cotton tip applicator. I recommend a polyester one rather than the cotton. The cotton tends to fray a little bit, so if you can find the polyester ones, they're a little bit easier to use. So basically, we're going to show me the injection site, and we'll go over it again.
For the right side,
Yeah,
we've got
you want to turn towards him.
just turn towards me. That's it.
So you can see it directly.
Midline, free-gingival margin, bisecting the angle.
Perfect.
In this area through
That's
here.
perfect, yes. That's exactly right.
All right.
So we're going to use our pre-puncture technique. Okay.
There we go. Thanks.
We're going to lay the bevel on the tissue at the injection site, just lightly on the tissue. And then you're going to put the cotton tip applicator on the back end of the needle. And then we're going to start the flow of the anesthetic. Yeah. You're going to hold it down until you hear cruise.
Cruise.
Take your foot off. Now it's on cruise control. Now after about 10 seconds, you can then just barely rotate the needle to just barely pierce the tissue. There you go. Now these lights that come on, this dynamic pressure sensitive, doesn't have any meaning with this injection, okay? Because they're coming on just simply because of the pressure. You really don't need the cotton tip applicator any longer. You're just moving the needle through the tissue slowly, 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 till you hit the bone. When you hit the bone, then you're going to stop.
Okay, we're there.
You hit the bone. Okay, now we're just going to stop and let the anesthetic flow. Now that gong just told me to use 1/4 of a cartridge. How you doing, patient? You doing well? Yeah? Good so far. Now we're using Articaine, 1 to 100. So how much are we going to give? We're going to give no more than 1/2 a cartridge.
So we'll wait
Now-
for 2 gongs.
Excuse me? Yeah, we're waiting for the 2 gongs. When the second gong hits, then what we're going to do is go into aspiration. Okay? Which means you're going to hit the foot pedal, you're going to release it, it's going to go into aspiration. After the 3rd beep of aspiration, you're going to take the needle directly out of the mouth and put it on the cotton, on the patient's bib. Can't see the injection. Yeah. Can you open up really wide now? Maybe we can get it. I don't know if we can turn towards this way. Maybe we can get a little bit better. We're trying to get the camera to, intro camera to see. There we go. Maybe we can see that. You can start to see the ischemia is starting. Okay, we heard 2 gongs, 1/2 cartridge. So you're going to hit the foot pedal and release it. 2, 3, out. Right here, out. Very good. Excellent. Very good. So, how was that?
Good. I didn't feel anything. Like, oh,
Good. Nice.
You want to rinse out? I don't know if we have any water going on here. I'll give you some water here. Okay, that was excellent. You did that so well.
Thank you.
I mean, that was your first injection.
nice one.
That's great.
So we're moving on to a
So
an
now
STM.
let's just look and see what it looks like in the mouth if we can. You can see actually, if we can get the intraoral camera in there, maybe you can open up a little, or put your head back. Yeah, that's good. And we can come in a little bit more. You're going to see the blanching. And you want your chin down? Your chin down? Yeah. There you go. That's better. Okay. Now you'll see the blanching that's going to occur throughout. I don't know if we can see the blanching already on the labial. On the labial over here, let's see what we can see.
Yeah, just close part way for me.
Yeah, I don't know if we can see it. Turn this way now, Mark. Let's see if we can get the camera to show it. We may be able to see it already starting, yes. Now, it will take just a minute or two for this anesthetic to have an onset. Okay, we can start to see actually blanching on that side. So,
But Mark, are you getting any numbness of your lip or your cheek?
if you
I
tap,
don't know.
No.
if you tap them down on your teeth, do you notice the difference from one side to the other?
Yeah, definitely.
Yeah. And your lip and face is completely normal. You can smile
Yeah.
normally.
Yeah.
Those of us that do aesthetic cosmetic dentistry, if you have 10 veneers to do, for example, all you need to do is give this injection bilaterally. You've numbed 10 teeth, including the mesiobuccal root of that first molar. Okay, so if I wanted to numb the rest of the quadrant, I would just give an injection behind the second molar. Now I've numbed the whole quadrant.
And that's a standard infiltration.
Yes, a standard infiltration.
Beautiful.
Okay? Yes. So basically, that's the injection that people use for cosmetic dentistry, aesthetic dentistry. Just last year, one of our top aesthetic dentists in America, David Hornbrook, did a demonstration, live demonstration, seating 10 veneers on a patient. That's all he did. Just gave those 2 injections.
Yeah, it's impressive.
And you can assess the smile line if you wanted to see what the smile line smile. Yeah, smile normally. Yeah, there you go. If you ask a patient to smile after you've given, how many different infiltrations, basically they
don't know
try
where
and
they
smile, they can't smile properly. And so you might have to have them back, let's say, to adjust the veneers you've just seated or crowns that you've just seated. In this case, you can do all that on the same appointment. So that's one of the basic advantages of this particular injection. Same thing with that PSASA injection that we talked about. Basically, that allows us to assess the smile line without the patient having this collateral numbness to their lip and face.
If you've just joined us and want to send in a question, take out your smartphone, open your browser on the smartphone, go to schein.tv and click connect, and you can send your questions in that way. So what's next, Gene?
Well, do you want to do an intraligamentary injection?
I
Do we
want
have
to. How are
time?
you
I don't
going,
know
Mark?
the time.
Yeah, I'm ready to go.
Yeah, on the anterior, okay. So in this case, we're going to break the handpiece short, okay? I usually keep the cap on so we don't have a problem. Maybe we can pull it out. I usually like to turn it away from me and then it just sort of snaps off short. Perfect. And I do that even though I'm doing an upper one. Sometimes it'll snap and sometimes you have to just bend it. There we go. I'll take it.
Thank you.
So we can do maybe one on the other side. I'll take this. And actually, you don't even need to bend the needle if you're doing a maxillary tooth. For example, you could do this upper molar starting on the distal buccal line angle, deliver a quarter cartridge.
Mm-hmm.
Go to the mesial buccal line angle, deliver a quarter cartridge, and then nothing on the palate. And you can take that tooth out. You can do endo. You can do whatever you want to do. Okay, so this is an incredible injection that we're going to show you right now.
We're going to work on the top left cuspid.
That'd be good.
Canine,
yeah,
yes?
sure.
Excellent.
We could do that.
So what's the technique?
You want to come in, turn towards you. You want to come in with the bevel towards the tooth at about 45-degree angle. Okay. You can do the lateral. Yeah, you want to start on the distal. Always start on the distal.
Yes.
The distal lingual line angle. So you want to come a little bit more distal and at 45-degree angle. Perfect. Now we just put it at the top of the sulcus, hit the foot pedal, and then get on cruise. As we do that, we're just going to move it down slowly. Until you reach resistance, right? Until you reach resistance, you're just going to hold it there.
Yep.
Now, is this pretty stressful for you?
It would feel
Maybe
like,
it is because it's the first one you're doing.
and
But
people are watching.
basically-
But
yeah,
it's
and
fine.
people watching you all over this country. But basically, it's now delivering the anesthetic and it's dripping into the bone. So it's going to take a little bit longer to give this injection than it would be if you gave a mandibular block, let's say. The difference is when we put this handpiece down, we start working immediately. Okay, so the onset is immediate, which is a lot different than waiting 5, 10, 15 minutes for a mandibular block.
So we're at a quarter of a carpule of articaine. Is this time to...
You could go into, we're just doing this as a demo, so you can take, there you go, 2, 3, out. Okay, now, this time I want you to hold it with a little bit less pressure, okay, because you saw a lot of that anesthetic come out.
Yes.
So basically we were using so much pressure that some of that anesthetic didn't go into the bone.
So less pressure this time.
So this, on the mesial now, we want to use less pressure or force on the needle. Okay, and come in exactly like that. Perfect. Okay, now you hit the foot pedal, go on to cruise control.
Cruise.
I don't know if we can see it. Maybe if you move, no, move that way. Then we can maybe see. We can't really see. Yeah, for the, okay. Put your chin down a little bit. Yeah. There you go. Now we can see a little bit better. Okay. So all you're doing is really holding it there in place with no pressure. Okay, and the anesthetic is dripping into the bone. Now I would maybe make it at more of an angle like this. Okay, that's fine. So it takes a good minute or two to give the injection. But like I say, the total time is much less. It's more efficient actually because you don't have to give a block, go out of the room, change your gloves, wash your hands, go do something else. Now it's finished. So wait about 4 or 5 seconds and then slowly back it out. Okay, just put it on the patient's bib and he's going to be fine. Great. Excellent, excellent. So
You okay, Mark?
really,
Great.
what
Yeah, really good.
we would do now is hit the back end of the mouth mirror, I would do it, and tap on this tooth and tap on the opposing tooth on the other side and ask the patient, do you feel any difference? Does one feel duller than the other? Oh yeah, this feels different. Well, then you can go ahead and start working immediately. This is the advantage, one of the advantages of using this technique and technology because basically you can start working immediately. The patient's lip and face is completely normal. They're not going to cancel your appointment, because they can't be numb, let's say they have a meeting or anything like that. How was that, Mark?
Oh, it feels really like I didn't even feel like I was being injected at all.
Okay, so
That is good to know.
you did it very well. Really, I'm very, very, very impressed with how you did your injections so well for the first time. Actually, what it demonstrates, it's not rocket science, but we would like our patients or the dentists that use this instrument to be well trained. So we have training that's online that basically we can go to a website called thewand.com, and that gives you a training video. These injections are all introduced by Dr. Stanley Malamed, and some of you might know Dr. Stanley Malamed. Dr. Stanley Malamed is actually the world's authority on local anesthesia. And basically, he introduces all these injections. So you can do that. Also, Schein has dentists in various parts of the country that are well trained to be trainers, to train dentists that want to use this technology and this instrument. And what's more, we have a group of dental hygienists in our home office in New Jersey that are very well trained, and we'll set up a training with any dentist that needs or wants training. It's free, and you can have as many trainings as you need. And this is very valuable because we want you to be successful the first injection, as Peter was. And basically, he had the ability to have somebody here coaching him along
some expert
the way.
guidance.
But it's very easy. It's nothing, too dramatic about it. But as you can see, it's a lot less stressful than, let's say, giving a mandibular block.
It is.
To achieve anesthesia.
So a question we have,
Yes.
can the wand be used for intrapulpal injections? I mean, you said
Yes.
it's good for everything.
Yes. Now, I didn't mention a third mode, and it's called turbo mode. And that flow rate actually is double the speed of the rapid flow. I didn't mention it because there's only one time that I would really suggest using it, and that would be for an intrapulpal injection, where you need force and pressure of the injection. Then I would put it on turbo flow, hit the foot pedal, go all the way down, and it would deliver a full cartridge in like 25 seconds. So that's, the only time I would use what's called turbo flow, but it does have turbo flow. It has another feature that I didn't mention that's really valuable for those dentists that use more than one cartridge. If you use more than one cartridge, you give an injection with a syringe, you have to pull out if you want to give a second cartridge, right? And then you have to reload, then you have to go back in and give another injection. In fact, this has a feature called multi-cartridge. So if you're going to give a mandibular block injection, and you can hold the needle in place actually, and after the first cartridge is finished, the dental assistant can change the cartridge, press this button that says multi-cartridge, and then it's not going to purge the second cartridge. It'll just continue the flow. So you can have the needle in place, you can keep it there, and there's no air in the system, and you can just give some dentists, believe it or not, give 3 cartridges routinely, and for them, or 2 or 3 or even 4. I met a guy that gives 4 cartridges routinely. And for those dentists that use multi-cartridges, it's a unique feature that nobody else has, and it's really beneficial to be able to stay at the injection site and not have to give a second injection.
And our next question, with the pre-puncture technique, does the needle have a tendency to penetrate the tissue when you place the cotton bud, when you're pressing the cotton bud?
No, actually it shouldn't, because the bevel should be flat up against the tissue. Okay, so right now it's not penetrating the tissue. Then the cotton tip applicator should be put on the back end of the needle and on the tissue. Okay, so it's really not penetrating the tissue till you want it to. So after 10 seconds, like I say, you have surface anesthesia. That's when you just barely rotate the needle to just barely pierce the tissue, which is almost impossible to do with a syringe.
And going back to the STA, again,
Yes.
we have a wand user watching, so thanks for your question. I'm using STA at my practice, but face problems with intraligament injection.
Yes.
If I hold the handpiece lightly, the light does not go to orange or green, or even the anaesthetic flow, and it seems the anaesthetic flows out of the sulcus. Is that?
Well, if you're holding it too lightly, then you're not making a seal. Okay, the dynamic pressure sensing comes on when you move the needle down. You've reached resistance at the bottom of the sulcus. You just barely pierced that epithelium. You're at the top of the PDL space. You formed a seal. That's when the dynamic pressure will come on. Okay? So if you haven't done that and you're just at the top and you haven't penetrated the sulcus, then the anesthetic might come out. Okay? Or if you put so much pressure on the needle that everything is backed up, at a certain point the anesthetic will just start flooding out of the tissue. So the key thing is to hold the needle handpiece lightly, move it down till you reach resistance, and then hold it there in place. These lights will go from red to yellow to green, but you don't have to get them all the way to green. And so sometimes the dentist will start moving the needle, start putting pressure on the needle to try and get the lights to go to green, and in fact that's the opposite of what you should be done. You should just hold the needle in place.
And in terms of like the different anaesthetic solutions used, you tend to prefer lidocaine or lignocaine. Is it just as effective with non-vasoconstrictor local anaesthetics?
Well, of course, if you don't use the vasoconstrictor, you're not going to have the duration of anesthesia that we're recommending. So in the intraligamentary injection, for example, if you're not using epinephrine, you're really not getting the duration you would need for most procedures. Although you can use whatever drug you want. We recommend lidocaine. It's safer, we found, number one. And number two, you get a better hemostasis and you get a longer duration. That's why we use it. If you're using articaine, just be very, very concerned about the dosage and never use more than 1/4 of a cartridge per site. And the dosage starts not when the lights go to green, as some people think. The dosage starts when you start the flow of the anesthetic. Okay?
Excellent. That's all we have time for today. I'd like to thank Jean for joining us for tonight, and of course you, our audience, for joining us as well. You can click the button below the video to register for your CPD certificate. Dentists in New Zealand can register for their CPD certificate by emailing Henry Schein. Thanks again, and see you soon on Schein TV.